Welcome. Today we're going to be talking about psychotherapy for people diagnosed with borderline personality disorder. So before we begin, I just need to make it very clear that here I'm talking about borderline personality disorder as it is conceptualized as a standalone pathology in which the individual has a discontinuous sense of self with moments of extreme elation and moments of self-hate that are very deep and unreconciled. Also, they are overwhelmingly afraid of being abandoned. This is the primal fear that they feel. This is to do often because often people with borderline personality disorder have had a lot of trauma happen in their life. So it's not rare for people that have this condition to also be traumatized or have a complex trauma. So keep that in mind, that it's about 80%, if not higher. So basically, how do we work with borderline personality disorder? Well, very simply, these people need to be welcomed in the therapeutic space. However, and this is very important, what's going to be the rule of the game with them is double way of framing sins. First and foremost, one of the most important sins is the setting. For them, more than other sorts of issues, they are going to need a very firm, very clear setting. For example, if therapy is once a week, it's once a week. It's not once every 2 weeks. It's not every month. Also, they might sometimes try and avoid payment. All of these things need to be very clear, and you need, as a therapist, to be very firm on the setting. One does not play around or fool around with the setting. That doesn't mean that the setting has to be fetishized, where everything has to go exactly according to the setting, but the setting has to be understood as something very, very important for their psychotherapy. Why so? Because basically the setting is going to be used by the clinician and the patient as a benchmark, one in which basically it's a guaranteed space in which the patient will be able to talk about, to basically free their emotional baggage. And the setting has to be constant because fundamentally one of the main issues in borderline personality disorder is the discontinuous nature of the self, meaning that they are, and as Kernberg would say, there are two versions of the self of the borderline, one happy good one and one bad and aggressive one. And because they have not merged together to give one unitary self, they're very divided. Therefore, with the setting, it's important to be constant because it's going to help a lot for the borderline to basically reunite both parts of themselves. Also, what the therapist should know is that working with borderline always implicates the fact that there are variations of mood that can go from very depressed to very aggressive quite quickly. This is due to the fact that, as I was saying, there are two sides of themselves which are not merged. In the same way, there will be two sides of the therapist that will be splits. So that splitting can happen basically with the therapist. For example, some days you're going to be the best therapist ever, some days you're going to be the worst and you're going to be complete trash. But it can also happen with the previous therapists, other professionals like physiotherapists, psychiatrists, etc., etc. What is important is that at the very beginning of therapy, borderline people need to split, need to diffract transference because it's too complicated, too massive, and the hopes are too high. So in these moments, if you feel, because this is also going to be very, very important for the clinician to understand that, is to listen to your countertransference, i.e. what you feel towards the patient. Because you have to be very careful with borderline because sometimes they need certain types of interpretations and sometimes other types. So for Kernberg, and I go back to Kernberg because he's the one that basically really frames it, I feel, the best. You need to have two basic lines of interpretation. One line that's more, let's say, common, standard, neurotic, i.e. interpretations on, for example, rivalry, on jealousy, on the idea of basically desire. And another one, more archaic, more early, that has more to do with interpretations on envy, destruction, repudiation, hatred, and so on and so forth. So one of the main things to keep in mind with borderline is you have to have the two levels in the back of your mind, i.e. you have to be able to switch from one another, because that's what happens with borderline, is that they're switching themselves between a more organized sense of personality and a more disorganized one. And the whole aim of psychotherapy is to try and unite both of them to make something more central, more capable of like staying constant and not switching from one to the other. Another very important aspect to it is the fact that you, at some point or another, will have to put certain limitations on the setting, on the relationship, therapeutic I'm thinking about, and basically on what you're going to do. Some borderline patients will try and push you to act out. So that acting out can be very varied, right? So it can be things like phoning their partner and explaining that they're very sorry, writing a note down for a professor to explain what happened. It can be writing for a lawyer, and so on and so forth. So here it's going to be very important, and I am a firm believer in this, that the patient should not be given what they're asking for. So before we have this whole complex debate on, but you're supposed to help the patient, not jeopardize the relationship, so on and so forth. The problem with the borderline personality disorder is that if you give in to those demands, you're going to be seen as two things, as all powerful because you've answered the demand, and as all good. So you might say, this is great. It isn't, and I'm going to explain why. So it's not good because if you're all powerful, then you can help them, you can save them, but the corollary of that is you can destroy them, you can hurt them, you can break them. Therefore, it creates some paranoid movement, very, how can I say, counterintuitively enough. Basically, if you give them exactly what they want, that will cause a form of resentment in them, because basically you are capable of giving everything, you're capable of taking everything away. Like a very early maternal imago. Melanie Klein talks about this, is that infants have this fantasy that mum is all powerful, she's all good and all bad, but both basically are on two distinct levels. A bit like the borderline, which has two distinct levels. So if you give in, basically that you're going to become the all good mother. But it's not right for therapy. Why so? Because A, you're depriving the individual from their own sense of agency. Because let's not forget this, that people with borderline personality disorder have to be able to own their own life. They cannot be re-merging with the object at each time there's an issue or each time there's a problem. Because that merger is not helping them develop as people, because they're going back to a more archaic state of infancy in which it's, please help me, please help me. And because borderline people can often be very touching, because they've, as I said earlier, they've survived a lot of abuse, the clinician can be tempted to act out for them. But unfortunately, often it isn't transformative. It just basically harkens back to early patterns in which the patient becomes tyrannical, and if you give them a bit, they'll take more and more and more, and they'll see you less and less as a therapist and more as a friend or as a parent that has to give them what they want, because if not, they'll feel not loved, they will feel that you're withdrawing from them. Then it will re-trigger the whole aspect of being abandoned, because if you've given all of that to them and then you retreat in that, they're not going to know what to think of that. So my position, and you do what you want with it, is that I am very firm on that. It's no, we're not going to do anything that's going to affect your life outside of this setting, and I will not act out. So often this if it's done earlier on, you might say, oh, it's going to create the setting, they're going to be able to go into it. No, often they are very aggressive. They start hating you, they start saying you don't give a shit about them, that you are just completely in for the money, you don't care, that if you really did care, you'd do what they asked for, and so on and so forth. So what I do is I explain it to them, that if I did it, I would be depriving them of their agency, something in which I truly believe, and that it's not up to me to choose for them, that they're adults and they have to understand that. So often the patient can get very heated in these arguments. And it's very important to make them understand that they have to basically live their lives, but you're there to help them emotionally take the charge or the responsibility of their lives. That you are there to help them emotionally process that in order to be able to go forward. For example, the grief, the hate, all of these things can be talked about, discussed, but you're not going to act out for them. You're not going to jeopardize the therapeutic space for them. And sometimes some of them can also understand that that would backfire on them. What I explained of that process of giving so much that then when you stop, you feel abandoned. Some people with borderline personality disorders have a good insight and can understand that yes, it would escalate, and that basically it's better for them to take a form of ownership. So often how it works on the day-to-day basis is that they will come in with a demand, with something, and interpretations can be made. However, and this is very important, you have to get ready for the interpretations to have not necessarily an effect of gaining insight, or not necessarily, not at the beginning, but have an action of acting out. Are you going to say something of like, for example, I completely fictitious example, right? But for example, you can say, oh, so you do fancy your co-worker. Perhaps you fancy them like X or Y in your past life, and perhaps you fancy them more than your husband. And the person will answer, this is untrue, this is a lot of bullshit. You're just saying that. And then, so you might think the interpretation has failed, or it has completely missed its mark. And a couple of weeks later, the patient is going to come back and say, I had a sexual relationship with that individual I was talking about. And so it's not necessarily wrong, and you have to be ready for them to act out the interpretation. That this is important because at the beginning of therapy, that's the only module or as a modality they know is to act things out. But slowly but surely, as you basically create a space of reverie, i.e. a moment where we can fantasize. What I mean by fantasizing is you can just imagine, how can I say, certain interpretations, and slowly but surely the borderline will become more and more centralized. Those two sides of themselves are going to reunite, remerge, as they can tolerate to see you as both someone that's hated and someone that's loved. Slowly but surely, what's going to happen is that when the therapeutic alliance develops, the borderline is going to remerge those feelings of hate and love towards the therapist to create a whole object, as we would say in psychoanalysis, i.e. they're going to have access to a new stage, which is ambivalence, i.e. they're going to be a bit bored with you, or they're going to like you and appreciate you and also kind of like see your limits and see why you're not great. And so it's great when they can criticize you without a level of emotional charge or of splitting. It's wonderful because that means that they have acquired ambivalence, that they have acquired a sense of stability to be able to criticize you without fearing repercussions, because that's very important, and without fearing that they will themselves will become bad. This is the utmost best, right? Ambivalence, both for you as a therapist and also for themselves, to understand that, well, they're not so great as what they feel, but they're also not as bad as what they feel. They are, in a way, human, complete and whole, with good sides and bad sides that come together. So this is also very important. As a clinician, you have to know when to basically accept criticism, when it's valid, when they make a good point, but also need to push back when, for example, it's about something that's fantasized or projected upon you as a clinician. So what I mean by pushback isn't like you're wrong, I'm absolutely not like that, but more like an interpretation. When it's like unvalid or unfounded, you must not have a relationship of basically of confrontation, but that of, see, it's interesting because this is not exactly what I feel. I have the sensation that we're closer to that. I have the feeling that right now you're seeing me like X or Y. Am I wrong or am I right in this? And often when the borderline is given an interpretation throughout therapy, not necessarily at the beginning as they might act out, but as it goes on, they might think, there might be something to it. I'm gonna think about it. And they start thinking, they start processing things. If we were in Bion's model, basically what the therapist is doing by basically giving this option is that it's creating a space of reverie in which he's creating a doubt. Not everything is all black or all white. Not everything is good or bad. Things are more nuanced. And by posing those types of questions to a borderline patient, by giving those interpretations, the borderline gains more and more introspective power that they can use to understand what is happening, to understand fundamentally who they are much better. Also, and this is very important, borderline people, as I said, have experienced trauma. At least this is what I believe. I think it's important to address that. For example, I don't know, if someone has been raped, I think it's important for the clinician to address that. You've been hurt, you've been sexually assaulted. Same goes for if the individual has been beaten by the caregivers. Very important to acknowledge that, because it's important that the borderline is acknowledged on what they've suffered, on the suffering they've experienced both as children and as adults, because it's a long continuum. It doesn't just stop at end of teenagehood and then we're adults and it's basically unabusive. Unfortunately, the patterns go on into adulthood. So it's basically very important to do a continuum, because often the borderline splits segments of that pattern and to not see the whole picture because they're afraid, they're terrified. So it's very important to try and reunite the pattern slowly but surely. Often, how I think of borderline, I think of borderline personality disorder and therapy as a very long process, because the whole point is to reunite slowly but surely. I.e., it can't be extreme, it can't be like in your face, absolutely right now, bang. It's more like slowly but surely every piece is reintegrated, every piece makes sense, every piece has meaning, and it follows a whole picture. And once they understand that, often it creates a feeling of appeasement, because they know that they can rely on you as a therapist, but they know that they can rely on themselves, that basically they have more sense of security. They go from a very intense sense of distress to a less intense sense of distress, then to normal anxiety. So it's more like, and how I see it with borderline patients, it's more like a spiral. Every time we ever get closer to the center, but we're not going to go there in a straight line, right? We're going there slowly, but every turn is a success. And I think that we have to point that out, that, for example, all the slow and good and happy moments have to be pointed out as a continuum on that line. A continuum that has to continue through the psychotherapeutic process. But there's also sometimes moments where the borderline are going to regress. So those moments of regression can be anything. Like, for example, they started thinking, they started taking a step back, they started being introspective, and suddenly they start acting out again. So this is important because this happens often. This should not be considered as failure, neither of the patient, nor of the therapist, nor of psychotherapy. What is happening in those moments is that the borderline individual is regressing because it's too complicated to maintain the new structure, the new sense of stability. Therefore, they're going down. It should not be considered as like everything is gone. Quite the opposite. Sins still remain, but at that point, the patient was too fragile to maintain it. Therefore, they go back to a previous state. So, what is important is to try and re-anchor the person into the positive states, let's say, but they're not gone, they haven't been wiped away. All the work the therapist and the patient have done is not gone, and that's very important to know it and to understand that everything is still there. It's just right now it's non-accessible, but that's okay because at some point it's going to be. And once they go back to that, they are able to advance. That advance is genuine and true, and one should not see it as either or, right? But it's a process, a continuum, and sometimes they need to regress to see if it's still there, if they're still capable of it. And often there's a real sense of joy and serenity when they see that they're capable of being there again, that sins haven't been destroyed, they haven't been annihilated, but quite the opposite, that they remain there in their minds and in the minds of the therapist. And also the fact of having a space that's non-rejecting, that has settings, right, and has rules, that's very important, but isn't rejecting. As long as the rules are followed, the patient is welcomed, and that's very important because the patient is going to have a true sense of security throughout those rules, throughout time, because it's both a question of time and a question of interpretation and of a question of setting. That's what's really fundamental in borderline personality disorder. Once those three criterions are met, basically the patient can develop at their pace, regress at their pace, and rekindle what was there at their pace. And that's fine. That's the one big advantage of psychodynamic and psychoanalytic therapies is that we take our time. And we understand that things are not linear, but they're discontinuous, and that's fine. As long as we, therapists and patients, pull the thread and try and create a continuous thread, that's what's important. So basically, this is pretty much it for this video. I need to say that I haven't talked about DBT and all those therapies specifically designed for them, not because I don't feel that they're effective, I think they might be very good, but I don't know them. This video is more about how I work and a form of trying to transmit to you, viewer, my clinical work and expertise. This doesn't mean that I'm going to, be perfect or that my methods are absolute or bulletproof, right? These things you have to take with a pinch of salt, as always. But I think that they're still very important and interesting. That's why I'm sharing them with you today. So do what you want with them, play with them, criticize them, everything's okay, right? If you have any questions, feel free to put them in the comments, and I'll see you in the next one. Bye.